Yeah, baby face over here. Look at you
Uh,
though. Shit, you got to be 20 years younger than me.
I am 37. I don't
Uh,
know how old you are,
yeah, yeah,
but
yeah. Yeah, you're a couple years younger than me. Shut up. I'm 14. Yeah, it's almost 15 years.
there you go.
Unbelievable.
20 years would be insane.
I know, right? But hey, don't I look
I
good
just
for over 50? I'm taking over 50.
There you go. Fuck
You
yeah, man.
know what?
Go.
Like,
Let's
look at this.
go.
This is no cocaine.
Yeah,
You've got
don't do
friends
the
that are
great.
like 35 and they look like they should have retired like 5 years
Yeah,
ago.
dude. I didn't do. I like My only vice was drinking for a long time, and then I stopped drinking in January, and I very intermittently drink now, and it's like it's good.
Yeah.
No nicotine, although I started nicotine a little bit, those freaking Zyn pouches. But homeopathic medicine says it's good for you now. So I
Yeah,
don't know if
wait,
that's true. I kind of doubt it.
hold on a second. Yeah, I'm not even getting paid.
Yeah, there you go.
Yeah, I smoked for
That
like 3 weeks of my life, but now I'm trying nicotine patches and I love it.
I told you, and the homeopathic medicine community is like patches.
Yeah, I'm all
Yeah.
for it, man. You should know
Hmm.
you're like a doctor on steroids,
Yeah, I mean, I don't do a lot of medical stuff, thank God. I just do a lot of surgical stuff.
right? Yeah, I want to talk all about it, man. I'm glad you're here for sure. I mean, I'm
Yeah.
not even real. I'm AI right now.
Oh, shut the fuck up.
Wait, wait, wait.
How cool would that be?
I
Just
know,
like
man.
set it. Dude,
I'm
that'd
not.
be scary though. Get a
I'm
little
not.
clone of yourself,
I'm not even here. I'm not even
yeah,
here. It's just completely
playing
automated
golf.
projection. This episode brought to you by the Atlantic Implant Institute.
Yeah.
If you're ready to grow your confidence in implants with full arch care, the Atlantic Implant Institute offers hands-on education built around real cases and real outcomes. Cadaver Labs, expert faculty, practical workflows. You can apply immediately. Learn more at theatlanticimplantsinstitute.com. Oh, sorry, my
Just
producer interrupted us with a little commercial break there.
Yeah, right, right. Just be careful. You don't want to be too robot, you know. I think they're saying Avril Lavigne's a robot, you know.
Aren't they all? Like, I think
I
like the
think they are.
president, I
Biden.
think everybody,
Yeah,
Bill
I was
Gates,
just
they're
thinking
all
that.
freaking aliens. All of them.
100%, man.
Today's guest is someone who represents the full spectrum of what modern oral and maxillofacial surgery has become. Surgeon, strategist, and partner leader. Dr. Zachary Brown is a dual degree oral maxillofacial surgeon who didn't just train at the highest levels, he's translated that training into real world surgical judgment, long term implant success, and leadership within a growing practice. And you've seen implants from every angle, top and bottom, hospital, private practice, complications, reconstructions. And now you bring your experience in the private practice sector in what city?
Kansas City,
Can-
Missouri.
Kansas City, Missouri. So today we're going to be talking about implants beyond Instagram highlight reel, decision-making failures, trust between surgeons and restorative doctors, and what really matters 10 years after the screws are placed. This is an honest conversation with a surgeon who understands that implants aren't just hardware, they're responsibility. Dr. Zack Brown, welcome to the All In, All on X podcast.
Hey, man, Adam, thanks so much for having me. Uh, Glad that you asked me to get on, and glad we made it happen.
Yeah. Yeah, I'm glad that you
Absolutely.
could be so flexible too.
Yeah, yeah. I mean, honestly, the benefit of having your own practice sometimes is you have some freedom, but then
Mhm.
you also have no freedom.
Right. Right.
Isn't that
Yeah.
how great? Isn't it crazy?
Yeah. I'm scheduled to do my next recording on Friday morning. And then I find out last night, my wife is like, no, you remember you were supposed to have the baby because I'm going to the spa with all the girls, our
Uh,
employees. And I was like, no, I don't remember that. But,
no, I don't remember that.
and she goes, it's fine. I can cancel it. It's fine. You can go ahead and do your podcast.
Oh,
I said, you
well,
know what? I
that's
think I can do it after work on Monday.
there you go.
Yeah.
Pivoting. Happy wife, right?
Oh, yeah. Do we want to talk about that?
No, not really. Not at all. Not at all. try to keep that as far out of my mind as possible. But I am, for all of you listening, I am going through a divorce. Almost done, thank God. So soon to be done with it. So
Yeah. Don't be a
that's a whole other podcast right there.
So when the ink starts to dry, let's jump back on because I had the divorce of the century in Virginia, and a lot of people can learn a lot from that podcast. So we'll jump back on when the ink dries, okay?
It
Yeah.
actually, and you own your own practice. It can have potential liability there. So for not only you, but if you want to have partners,
Yeah.
it's a whole thing. That's a really good topic, actually.
It needs to be said because I mean I even had
Yeah.
a practice. I have a practice all on my own still, and it was still monumental and the things we had to discuss. But
Yeah.
I don't want to get you in any trouble, talking
Oh, that's
about that
okay.
before the
We'll let the ink dry first.
let it you know you know why divorces are so expensive, right?
Because they're worth it. That's what everyone says. 100%,
Yeah.
man.
And we just lost 51% of the listeners
Oh,
there. No, I'm
that's
kidding.
okay.
I'm kidding. That's all right. Let's jump into surgery. Wait, let's jump into
Yeah.
you, man. I, I've known you pretty well. We've been together at in Guatemala at Orca a couple of times, and
Yep.
I've been seeing you traveling around with you. I've seen you at some other places. I feel like I
Yep.
know you a little bit, but you still escape me because I still got to understand real Zach because you're this authority on dental implants. But yesterday I asked you what you're doing, and you're plating a jaw. You're doing TMJ. You're doing orthognathics. And I feel like I
Yeah.
just don't know a lot of oral surgeons who are so busy in both worlds. Or am I wrong?
No, yeah. I mean, I'd say it's hard. The pendulum swings, I feel like every 10 years maybe, I don't know. We basically a lot of oral surgeons come out and they're probably jaded from a really tough or malignant residency, and you're kind of told like you can't have a practice that allows you to do hospital medicine or hospital surgeries, I guess you could say, and then
Right.
also make money. You have to go into academics, and then you're kind of relegated into, academics for life for you to end up making enough capital. So, not a lot of oral surgeons really come out of the gates wanting to, and if they do, the support really isn't there for them. So then people drop off pretty quick.
They drop off
So
the surgery. They
they
drop
just
off the
stop.
hospital.
Hoffs, yeah. They'll be on for a couple years. Our boards require you to be on for a couple years. Most hospitals don't make you take call though.
Mhm.
So, I don't know what I did. I came out, I wanted to do hospital surgeries. I wanted to do TMJ. I wanted to do orthognathic. I wanted to do trauma. Wanted to keep that going. And actually, implants for me were kind of almost a sidebar.
Mhm.
I came into a practice that did a lot of singles, like one implant, two implant for referrals, but we were only doing like 3 arches a year, and
Mhm.
so when that happened, I was like, "I need to do more arches," because we basically weren't doing them, and there wasn't enough volume to even keep me busy, so I was like, "I'm gonna hammer on all on X." I know how to do zygomas, taught myself how to do pterygoids because I don't teach that stuff really,
Right.
and so that's kind of where I started, and now I do probably, uh we do case, like I basically do a full arch case a week within the practice. Not always me because I don't like funnel referrals. So basically, myself, my partner, any of the associates will be doing a case. I would say generally I probably do some of the harder cases mainly because they refer that way. But
Right.
so I'll do a lot of salvage reconstructions, and then I have a day a week I'm in the hospital. TMJ reconstructions, orthognathic surgery, disc repositionings for joints, scopes. So I do a
Mhm.
lot of full scope, man. It's a lot of work, a
Yeah.
lot of work.
So does they're both surgical practices, obviously, but the hospital-based surgical practice, the TMJs, the orthognathics, does that ever play hand in hand with the full arch all on X, or is it two totally different worlds?
I mean, I would say surgical skills are kind of across platforms. Like even in your when you're in training, I did general surgery, right, for a year. You do general surgery and even your surgical principles in that realm. play into what you're doing with full arch. So I think that definitely, like just hemostasis, good clean flaps, good clean dissections, having all your tools ready, having
Right.
all your support systems like before you jump into something, know what you're doing, have a plan,
Right.
those things are kind of universal. So yeah, I think it does. I think occlusion and orthognathic surgery and occlusion in full arch, they play kind of some hand in hand,
Right.
similar to, I think, like cosmetic dentistry and full arch kind of probably have a lot of that marriage, orthodontics. Like
Yeah.
smile design is important across the realm. And so definitely they all kind of go together.
Yeah. My GPR year was 2003, and it was a hospital based, um, heavy in orthognathics. And I think when I started my
Yeah.
full arch journey, I started doing model surgery, and I'd realized, and I started
No,
treatment
yeah.
planning according to the condyles. And I think it took me a few years to realize I was doing orthognathic treatment planning.
Yeah. Dude,
Yeah.
and now you think about how that relates what you went through for model surgery and how to get a good scan and all that stuff to how we relate arches in surgery now with virtual planning. I mean, all that stuff, it never goes away, man.
Your residency was, did you do model surgery? When was that?
So no. So I did 2 model surgeries. I got lucky. It was like right after everyone spent like 6 hours every case, staying up all night doing model surgeries. And then 2 years before I started, they kind of cut it out.
Yeah.
All virtual planning, 3D printed splints. And that was in 14, 15, 16 is when they kind of really flipped it over. So I did one case
Uh-huh.
from Ed Ellis. I did one case with Dan Perez, and I did model surgery. Took me forever, all night sweating. You move like the wax, and one tooth moves, and then like everything moves. All
Yep.
your hard work went to crap.
Yep.
Uh, and I did that. I did two. So you probably have done more model surgery than I have.
To be fair, I was a scut year zero, GPR resident watching oral surgeons. I probably watched more, but I definitely had to
Yeah.
cut some apart. I was the guy
Hmm.
in the operatory that was just like trying not to fall asleep while you retract the whole time, and
Uh
then,
huh.
but then I learned how to post op. I learned how to round. I learned how to follow up and care for people afterwards. Big time.
Oh yeah.
Yeah.
It's
So
that's the stuff that people take for granted. The surgery ends up being easy. It's the patient management and the expectation management and the post-op and the
yeah.
complication stuff. That's the hard stuff.
Yeah. So tell me about I totally fully agree. I try to run I'm just a dumb GP. So but I
Yeah.
try to run it based on what I've heard with, my experience with the oral surgery program, in rounding on people and following up on people and having frequent recares. So I get
Yeah.
it. But complications in orthognathics versus all on X. I mean, you see any like similarities?
Yeah. Well, yeah. I mean, I would say complications in orthognathic surgery are pretty uncommon. Usually they're like a surgical complication. You have like a bad split. You have, but I've had a couple. I mean, I had a oral nasal fistula from a 3-piece, used a Sonopet, which is like a very high powered piezo,
Hmm.
in the OR, burnt some tissue, man, and had a hole. Took
Yeah.
a year. I think finally we're closed. Thank God. But, it's
Is
like
the
one of those
pet
things you're still holding your breath waiting. So I think that kind of right? I mean, and then you see the patients come back and you
Yeah.
see their name on the book and you're like, "Good,
Uh-huh.
are we good?"
Yeah. Yeah.
Same thing with same thing with, like, I'd say zygomas. I mean,
Yeah.
long-term management of if you have a oral nasal fistula, oral antral fistula, if you have a
Mhm.
oral nasal fistula is pretty rare, but oral
Right.
antral fistula, you have, you know soft tissue dehiscence, all that flap management, it's,
Right.
same similar complications.
Yeah. You ever have a
Um,
complication that really humbled you, like the worst complication ever? If you're ready to legally talk about it, if it's past the statute of limitations.
I mean, honestly, I would say malocclusion and clenching. So,
Yeah.
if any of you surgeons out there are all surgery oriented and you don't care about pros, like probably I was a little bit more when I started, this journey. Um, you need to spend time on the pros. so much more than what you think because, you have malocclusion and you're like, it'll buff, right? No big deal. A little, they're biting it. They have a little contact everywhere.
Just grind it
And it's
in.
just
Just
like,
grind it
yeah,
in.
just grinding it. And then, man, they come back like, and you didn't pay attention to them 3, 4 weeks later, they're only touching on one side and it's like a quad zygoma,
Mhm.
and you
Yeah.
have a failed zygoma and you're like, I was taught this never happens. Like, how do I fix like a zygomatic implant failure, And
Right.
you got to figure out pterygoids. You got to figure out subs. I mean, so yeah, spending time on occlusion was probably my biggest thing because I've had mainly the humbling thing is heavy occluders and poor occlusion management. I think probably explain away 90% of my failures.
Yeah.
Otherwise, I mean, every once in a while you have an implant that maybe you didn't have a passive fit with like an analog because I used to do a lot of analog. Maybe you didn't get a passive fit on an analog conversion or
Mhm.
whatever it is. Take out an implant, place a new one. I think probably my biggest weird ones I've had. So I'm a referral based oral surgeon. I
Right.
do a lot of work training the dentists that I work with on the pros side of things. I do a lot of the pros myself to help to make sure
Right.
that things get done correctly because they're complicated. And if you're doing one or two a year, you're really not getting enough, reps in to manage kind of tough occlusions.
Oh,
And so
yeah.
I do a lot of that. And I had a case quad zygoma before I was doing pterygoids. Now every posterior, almost every case gets a pterygoid now,
Yep.
whether they need it or not. And every posterior zygoma gets a pterygoid. I
Mhm.
never place a zygoma without a pterygoid. Because it's just such a long implant. There's a lot of
Yeah.
flexure within the
Yeah.
implant. You get a lot of ditching. You got to
Yeah.
have something to help prevent that
Yeah.
flexure and stress at the crest. And so this patient comes back 2 years later, still in a temp.
Mm. Yeah. I get it.
Screw- Screws were loose, implant broke at the cheek, just a mess, huge fistula. She's like, I feel like it's moving a little bit. I was like, yeah, I'm surprised it's in your mouth, man. I mean, like, what the? Oh,
You're like,
so,
get out the jaw fixation bars, get out the arch bars. They're gonna put the bridge back together.
oh man, it was rough. That's probably my worst one. My worst one. And
Yeah.
um did
I like
transnasal pterygoid and a zygoma. And I got the hole closed, got lucky. Um
yeah,
Actually did really good uh like side by side of
yeah.
what the transnasal looks like versus the anterior zygoma that had a huge dehiscence. I would say my personal thing is I do transnasals on anteriors all the time now. So
I think I saw that. I'm gonna try to pull this up, but I think I saw that on your Instagram page. I was looking through
yeah.
there this morning, and I think it's this number one, is it not? Is this what you're talking about?
Uh, it might be. I mean, so
Oh,
this is probably I planned it this way because I
okay.
was trying to get around an anterior zygoma. But yeah, man, I mean, I prosthetically look, they're not that anterior implant, the transnasal versus the anterior zygoma, not that far off. But
Uh-huh.
I have some long-term soft tissue follow-ups now. And man, a transnasal is you're still gonna have a little anterior cantilever, but honestly, anterior cantilevers aren't a huge problem comparatively
Yeah.
to having a huge dehiscence on a zygoma. So I love transnasals nowadays. I mean, if it's a quad, I'd rather do it. If they have it, I'll do transnasal all day.
But you need 5 or 6 millimeters of bone on the floor of the nose, right? Yeah. You
Yeah.
need you
And
need
that
that.
was a mistake I've made too.
Yeah.
Ask me
Right.
how I know you need that much.
No, I can imagine. So you're the big zygo, like one of the zygo kings. You love zygos, but now you're loving transnasals.
Yeah.
Um, everybody's calling me. Everybody's calling me because we just ran a remote anchorage class here this last weekend with
Yeah,
Juan
very cool.
Gonzalez and Sam Jarek, and we had
Yeah.
cadavers and everything, and it was fun. Live surgery, hands on. It was great, great course. Next one's in May, by the way. A little plug for remote anchorage here in Virginia Beach.
Very cool.
But yeah, it's everyone calls me and they want to know, how are you going to cover transnasal implants now? I'm a general practitioner, I'm a dentist. And a lot of dentists are calling me transnasal implants. Do you think that they should be as rogue about doing those as maybe learning pterygoids as zygos, or are they just the same, same risk level for everybody?
I mean, so when I look at transnasal, honestly, I haven't seen. I think there's still a newer approach. I think we definitely don't have like pterygoids were placed long ago. I don't know how many transnasal like long term follow ups there are like 10, 15 years out. Like I just don't know that that exists.
Right.
Um, and so I'd say that the jury's still out on long-term stability if you're not following some of those rules that you're saying. So like plicate that
Yeah,
acronym that they've made. I think Holtzclaw and some other people wrote that, right?
I think so.
But it has like all the little things you should be looking for. How much bone at like the Z point area, how
Right.
much subnasal bone you need to have. I think those rules are pretty appropriate. But if you have it, honestly, I don't feel like it's much different than like a trans sinus implant. You know, you're redirecting through a space. You have a posterior apical stop and you have some crestal bone. And I don't think it's as scary as like I think the dissection on a zygoma is harder than into the nose. I think there's a lot less blood vessel
Hmm.
risk than a pterygoid.
Sure. I
You're,
agree.
you know,
Yeah.
so long as you know where the orbit is, which I can only imagine
Right.
somebody someday is going to be crazy enough to somehow go too far. I don't know how, but like
Yeah.
22, 24 millimeters is the vast majority of those implants.
Right.
That's the length, man. And I just feel like it's probably safer. It's easier. There's a little bit of bleeding, from
Yeah.
the nasal walls, but it's not like a major blood vessel.
Yeah.
You tamponade that off. You can use a little bit of a Bovie. And then if you get a little bit, I've never seen a fistula. I've never seen, and I'm sure that there will be some, but
Okay.
the nasal mucosa is thicker than the Snyderian membrane. It's
Oh,
very
yeah.
forgiving.
Oh, it's huge. It's thick. Right. So you
Yeah,
think it's
I don't know. I'm not as worried about it.
easier for doctors to learn it in the opposite direction? Maybe transnasal zygote, where we're basically teaching pterygoid zygo transnasal. You think it should be the other way?
Yeah, I mean, I would say I would make an argument, and I have a presentation on this. Anytime I can do a transnasal instead of an anterior zygoma, I would do it. You're staying away from the orbit. You're staying
Right.
away from a huge dissection.
Right.
And those long zygomas, that's where
Hmm.
you're going to have a lot more of the complications. I mean,
Yep.
and dehiscence
Yep.
and administrations. And, you know, you don't have that with the trans. It's almost similar to a tilted implant. You're just
Right.
skiving off of a bony wall and getting
Yep.
into a good spot.
I've got a few, I can think of a couple, so there's probably five if I can think of two, but I can think of a couple quad zygo cases where the patients say that they don't have pain, but they definitely have feeling and they don't want to call it discomfort, but there's something happening when they bite on their front teeth on that long anterior superior zygo. And if you look at, I just showed this last weekend in class with finite element analysis, that if you look at lateral forces against a zygo, it's very good, very favorable. But you look at compressive forces on zygos, and it's very unfavorable for a zygo.
Yeah.
And it just makes like you say like no duh, like no shit.
Well,
It's good. You got this
it makes sense,
55
man.
millimeter implant going off to the side. You try to load it axially, and it's gonna have some flexure.
Yeah, I mean, if you could, I mean, that's the thing about quads is if you can get like a small subnasal implant, like in the inside the papilla area.
Yeah.
I mean, hell, I mean that's game changer because you
Yep.
prevent that flex. But man, I'll tell you what, it's if you can avoid a zygoma, always avoid it. So I
Yep.
feel like
I agree.
transnasal palatal approach,
Yeah.
pterygoid, all that stuff. I hope that's the new wave, and zygomas go back to being that,
Yeah.
second level. Because I feel like people got zygo happy. You know,
I
there's a
did.
lot of those.
I
Yeah,
I for sure did. I gotta like we're getting to do a zygo. Look, I'm gonna put you in my clinical note for my case this morning. You just justified. I did pterygoids 60 plus. I did
yeah,
tilts 60 plus, and they were 15s. And then this patient of an ethnic descent was missing all of her teeth and had
Wow.
just a plate of bone for like 6 through 11. And I
Yeah,
just went palatal because I have
absolutely.
60, 60, 60, 60. I mean, I'll just go 10, 11 and leave it palatal rather than go to the zygo, you know?
Absolutely.
Why,
All day.
So Zach Brown said, give me a minute. I got to write a chart note.
That's a that's what I would have done in a heartbeat.
Yeah.
Nowadays, I look at X-rays that I did, because I've started following up on my patients more frequently after seeing them get released into the wild and coming back with problems. So I follow them up more frequently, and I find that those cases, maybe 4 or 5 years ago, that I did with
Hmm.
zygomas, there's a chance, man, I could have done it with the techniques we're using more now, like palatal approach, and it's
Yeah.
crazy to think how atrophic you can still get some bone in the alveolar ridge area, man.
I look at cases I did 12 months ago and I'm like, I look at cases
Y-
I did like
Yeah.
6 years ago or 10 years ago, for God's sakes. And I'm like, God, I hope that doesn't end up in Zach Brown's office. And that's like, you
Yeah.
know, or
You'll be the one
people,
to fix bone stuff.
2016, I actually have a patient that called looking for records and they wanted to go see somebody in Texas, 2016. And
Oh,
I'm
yeah.
like afraid to look at,
Oh,
I got
no,
to send
no,
it to a
no, no.
friend. I don't know, but I'm afraid they're going to be like, this is all of Hogan's work. I'm like, no, it's 2025, guys. It's 2025. Got to
Yeah,
be a little better. I'd pretty much
dude.
redo everything. I don't know. Like, have you ever had a case you're just like, oh, perfect. Everything. I mean, you got
No,
better cases, right? But
no, no. You look. I feel like I hopefully most surgeons humbly can always look at any post-op X-ray and be like, man, couple of degrees here, because that's how we get better. You don't get better by thinking that you're perfect, right? You get
right.
better by critically looking at every case you do and figure, man, I really could have done this a little bit different, or I could have added this, or this could have made me a little faster and more efficient. Like you should always be learning and always be, evolving. Otherwise, I mean, you're bound to find yourself making mistakes, and you know, you
Yeah.
just gotta
Do you
do it.
do you find through all your training that you're a more aggressive or more conservative doctor these days, or what makes you which one? Why?
I would say residency is a lot of people say this. Residency is made to tell you who not to treat. Okay.
Yeah.
Because you treat pretty much everybody. Everybody that walks in the door, this is a maximal resident benefit case. I'm gonna
Hmm.
learn about this case, especially if it's a resident run. Like, let's go. Let's take out the styloid. Let's do TMJ replacements on this like 18-year-old kid. Let's get surgery done. And
Hmm.
you learn through like follow-ups and maintenance, like, maybe the more conservative route is always is better. So
Yeah.
I mean, from a TMJ guy, so I do a lot of TMJ stuff. I see probably a couple TMJ consults a day. I tell a lot of people, hey, you have some clicking and popping, you have some pain. Let's not do any surgery unless we've done everything possible. And I'm that
Right.
way with teeth too, man. I mean,
Yeah.
I I've started direct to consumer, for example. I
Hmm.
get a lot of patients that have a lot of good teeth left. I'm like, listen, you've got two options. They may even be
Yeah.
somewhat equal in price. If you're doing a lot of crown and bridge with
Yeah.
single implants, I mean, it's going to be expensive too, but long term, maybe keeping some of those teeth is better than an all on X. You just got to kind of weigh the pros and cons, man.
Yeah.
So I sent a lot of cases out that came in for all on fours. I'm like, maybe let's get a good restorative plan first.
Yeah. I think that that's a great method, a great way to be. I mean, I'm basically doing all on X clinic, but you really have to check the psychological well-being and the
Yeah.
psychological position point of that. And hey, can you go through XYZ? Are they the same price, but this one's a year longer? Is it, sometimes the conventional route is more expensive and 2 years long,
Yeah.
and that comes into play. You know, I'm not a proponent of pulling out all my teeth, all of anybody's teeth for sure. I don't want, go on the record saying that. But if you go back in plastic surgery 30 years, 40 years, 50, well, definitely 40 years, there was a lot of plastic surgeons who were frowning on the elective cosmetic procedure, and there was
Uh,
there was a
yeah.
battle going on in plastics. Like, are you going to touch that healthy face? Are you going to reconstruct those healthy breasts? And if you're aware of the history, do you feel like dentistry is at that road right now?
Well, I mean, think about, I mean, I think for sure. I mean, I feel like cosmetic dentistry, for example, I think cosmetic dentistry is even worse than all on X because I feel like most people are not taking out a full set of good teeth. You
Right.
know,
Yeah.
most people aren't doing that. I think, but you make a full mouth rehab case and they're all healthy teeth
Right.
and they just want them to look a little different. I
Hmm.
mean, you really, that's where you get into some weeds, man. I find like I have I have white, somewhat straight teeth,
Yep.
right? They're end on, they're ground down.
Right.
I mean, they're not perfect, but and I've had cosmetic dentists be like, "Hey, I could let's do your let's do your upper 12, man. Let's get this looking perfect." I'm like, "Absolutely not. Leave my
Uh-huh.
teeth alone."
Yeah.
But they're selling that to people that will definitely bite, and I'm like, that
It's
is
true.
definitely a I think that's more in the weeds than all 4.
Because we're going to do something conservative and cut 3 millimeters of enamel off in all five directions. you know?
Yeah, well,
All right.
but then their teeth, I mean, people don't think about this. There's a life expectancy
Right.
for everything that you do in your mouth,
Yeah.
even on 4. And that's, I
Right.
think, a thing that people need to make sure they're like, listen, I'll tell people that if you were perfectly healthy and everything goes perfect and you take great care of these, sure, you can get that 95% in 20 years study.
Yeah.
Sure, that's great.
Right.
That's possible. But we're here now for a reason.
Yeah.
And, your teeth were bad for a reason. You got
Right.
to be able to take care of it, man.
Yeah.
So,
No, I couldn't agree more. But I do feel that there comes a point too where you got to help people psychologically.
yes.
I think of a woman that was in her 60s. I treated that. No, she had tetracycline staining on her teeth. She had a history of periodontitis, all currently stable. But we had
Yep.
a high transit, we had a high smile line, you name it, it was a hard case. Nobody wanted to help her. And she was depressed her whole life. And,
Yeah.
the periodontist was always like, we can keep your teeth one more year, one more year, one more year. But she was depressed her whole entire life. I finally, after
Yeah.
listening to her a couple of times, we replaced her teeth. And, I realized that there could have been a dentist that could have helped her live a happier life 30 years ago, you know?
Yeah.
But everybody's, well, do no harm, which I respect.
You gotta, there's definitely that middle ground. Same with dentures, take out their teeth, saying dentures an option. I mean, dentures are awful.
Yeah.
Have you ever met somebody that was happy with their dentures? I mean, like that one person was like, I don't want implants for this. Like everybody hates their dentures. So, I mean,
Right.
there's definitely that borderline where it's like, we definitely should treat a lot more people for
Yeah.
sure, especially in all 4.
Yeah.
And, the corporate guys, and I'm not corporate, so I don't know. And I can't speak to everybody, but, an arch isn't always an arch. Sometimes it's a couple implants and some restorative. That's okay. You should be able to do that. And sometimes it is. I mean, you got to talk to the patient about our options. So,
Okay. Yeah, I got to tell you a wild story. I'm not kidding.
yeah,
Uh,
yeah,
I,
yeah.
I did have one patient who was happier in her denture. And,
No way.
yeah, well, this is a true story, so don't crucify the storyteller.
Oh,
She,
dude.
was having trouble at her job. I found out later she wanted her implant bridge out because, it was hurting her business. And she was on OnlyFans. And
Oh,
she wanted
no.
her teeth out. True story. Okay. True,
That's awesome.
true story. Yeah. One of these days, maybe over a cup of coffee or a beer, maybe since we're not both drinking anymore much, but after
Yeah.
one beer, I'll tell you how she came out and divulged why she wanted her teeth out. It
Yeah,
was,
I can't imagine how that conversation started. Like, they're beautiful, but
uh, this is not for this audience right now. Not for this
oh,
audience. I can't.
Yeah.
truth is stranger than fiction. I can't make up what people tell me in this business. It's unbelievable.
Yep. Oh
I,
yeah.
it's crazy. I want to go
Well, and
back.
then you get the life story, you know. I do a lot of my consults myself. I don't do the treatment coordinators come in and talk and seal some deals. I do a lot of my consults myself because I feel
Yep.
like I can really drive home like the value that you're gonna get out of having a fixed set of teeth.
Right.
So, but sometimes, man, you gotta go through the whole life story.
Well,
When I was 6 years old and I had my tooth worked on, you know,
yeah.
all the way up to
Yeah.
today.
Yeah.
Yep.
I do my consults myself. And I've got treatment coordinator salespeople, for lack of a better four-letter word,
Sure.
that sell the case, no doubt. I only do it to meet them and realize if they're crazy or if I'm friends with them, if I could treat them.
Yeah.
And because I don't want to treat people I don't like. It just, if you get a complication and you don't get along, you're in a bad, bad place.
Oh yeah, man.
Yeah.
I that's like I said, residency teaches you who not to treat. And the psychology is a lot of it.
Yeah.
Especially you talk about the people that want better looking teeth but have decent teeth already, and
Right.
you're taking them out to make this beautiful zirconia all in four.
Yeah.
You just manage expectations, man. That's number
And th-
one.
they're going through their phones, showing you all the real housewives of whatever city and the ones they like and don't like and the ones they want to look like and not look like.
Was this the OnlyFans one or who was?
No, 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 this is one I just had like 2 weeks ago.
Oh
And
no.
I just texted in my group about it. Turned out beautiful, but we did an upper FP1 in the Full Arch Addicts WhatsApp group. I just texted because my media guy just got me her photo from after surgery. It was 2 days after surgery. But we did upper FP1, lower FP3. But in her consultation, like this woman was a lot. And she was very animated. She was going through her phone, showing me movie stars. And I said, look, if I'm going to proceed any further, I'm going to say two things. One, you are never going to pull out your phone and show me a movie star ever again. This will not work. We're not going through Hollywood. I said, two, I need to know, can I make you happy?
Yeah.
Are we going to finish? And I was about ready to dismiss her. And she looked at me and she goes, Dr. Hogan, I know I'm a lot, but yes, you can make me happy. I will be reasonable.
Yep.
So, and we did her upper FP1, lower FP3, and she was ecstatic, but I almost had to say no.
Yeah.
No.
Well, and setting a boundary, there's a lot of people that get excited, right? You have somebody that wants potentially a somewhat lucrative procedure. It's a
Right.
fun surgical procedure. You're excited. You got somebody in the chair and you want to sell it and they want to bite. But I mean, you really have to manage
Yeah.
those expectations from the get go and set boundaries, not be a yes man. Use your doctor brain.
Right.
Make sure that everything feels right. They come back and I've had 3 consultations with 3 different dentists. None of them, they're all hacks, whatever. That's a red flag. You know
Yeah.
what I mean? Like
Right.
somebody with super high cosmetic expectations,
Yeah.
that's a red flag. You gotta manage them, you know?
Best thing to do is not bring them in. Don't bring them in. They
Yeah.
say the best case is the case you don't do, right? Um,
Yeah.
hey man, you are, first of all, you're oral surgeon. You're so freaking grounded, man. You're so humble.
Ah.
I gotta say, like, I'm not saying that all the oral surgeons out there aren't, but you definitely meet some guys that have you know, the little chip on their shoulder. How do you do it, man? How are you so cool?
Me?
But you're so
I
super
don't know if I'm that
educated.
cool. I'm not that cool. I I do everything honestly. All right, so I'll get a little bit into this. So about 9 months ago, my life kind of crumbled. All right, I
Okay.
had a divorce started. My practice life was rough, and I'll tell you the one thing I feel like, especially medical professionals, we do is we don't take care of ourselves very well, and so I had stopped drinking in January for no, but January, I
Mhm.
just kept it going. Went to the gym, prioritized myself. And honestly, I'll tell you, prioritizing yourself feels selfish, but you can give the best of yourself to everybody when you're doing that. And then my practice life is great, man. I get to do everything I want to do. I do it at a high level. My patients have relatively good outcomes. I can't say I'm perfect. No one's perfect. Like, complicate if you're not if you're not having complications, you're not doing surgery. You're not doing enough surgery.
Right.
Statistically speaking, we're all going to have complications. It's how you manage it, how you set the expectations with your patients. Um, and I don't know. I feel like the other thing is I do a lot with Orca,
Yeah.
and in the beginning, because I'm an oral surgeon, I'm dual degree, woo, but like teaching general dentists how to do some of this stuff was in the very beginning kind of tough. And then I'm getting into it. I'm doing these surgeries, and people that are like at a high level focused on just on for it, that is their surgery. You know what I mean?
Right.
Are doing it better than some of the oral surgeons I've met. So I'm like, you can't judge a book by its cover or the training that you expect that they had because of their letters, right?
Yeah.
I mean, I
Right.
feel like that's just not real. People can be trained. That's what training is for. So if you're getting trained on a high level and you're showing up and doing the work, I think that's valuable. So I don't know. There's a lot of little things, I
Right.
guess.
Yeah, you're speaking my language. Now I have full permission to keep on practicing at a high level.
You've been blessed. You're good to go, man.
I I gotta tell you,
You didn't need it from me, but I'll give it to you.
it, it's not easy. It's not easy because I mean I do meet people of other specialty practices, and they're hey, in town here I've got like 4 or 5 oral surgery offices that are referring me full arch. They don't want to do it. They want me to do it. They've seen my work, and I've probably got 4 or 5 that just can't wait for me to hang myself. You know, so
Yeah.
like, but they probably never seen my work too. But I don't know. I guess that's just
Yeah.
society. I mean, do you have any advice for general dentists in their communities?
Uh, well, so if someone has a problem with you, that's their problem, not yours. That quote is a very stoic kind of thing. It's Marcus Aurelius, but that quote can kind of give you some confidence, right?
Yeah.
If you're holding yourself to a high level of integrity and you're doing the work and you're learning how to do things and you're not operating outside of your bounds and you're spending the time, you go to a live course like this, you do a cadaver course, you do more than one, you can't substitute like a 6-year level of training or a, you know, 3-year prosthetic residency into just weekend courses and then reading about it. Like you need people and connection and, rounding out those skills with real life practice. If you're doing those things, I mean, there's no reason you can't. And just make sure you have mentors.
Yeah.
Make sure you have people that can help you to get you out of messes you get in and don't get into messes. Manage your patient, manage all that stuff. So that's a start.
Manage your manage your complications, keep
Yeah,
relationships, keep dialogue open, have mentors, people
and
that can
have
help you out when you need
mentor.
advice. Yeah,
Absolutely, absolutely.
for sure. I definitely will have complications. I think one thing that, people need to know is that having a complication does not mean you're operating below the standard of care. You have complications. People have
Yeah.
complications,
Oh yeah. I
right?
mean, implants fail. They're not perfect. I honestly, I'll tell you, full arch is rare to have a ton of implant failures, but you have to manage the single implant that fails, whether it's a zygoma or pterygoid or whatever it is. But you suffer a lot more for a full arch failure than you do for a single implant failure. I mean, you really do. I think
Sure.
sometimes it's harder, way harder. Um, but yeah, I mean, complications happen. You gotta be able to manage it. And if you're like, so for me, I have a pretty low complication rate statistically. You should be tracking that. You should
Mhm.
keep track of the implants that failed. Think about why they failed. Think about what you can do to improve. There are cluster failures.
Mhm.
There are, you got to change out your implant drills. You've got to make sure your sterilization processes are always on point because you're probably not sterilizing your stuff, are you?
That's right.
Somebody else is.
Yeah.
So
No, it's
you got to
true.
manage those things on top of your own surgical skills. So, I mean, I keep track of them. I think everybody should. And then you got
Yep.
to critically look at them and it takes time, but you have to.
Yeah. We keep a spreadsheet in the office, and probably need to look at it again. It's been a few months, but if we have an implant fail, we're supposed to. I have somebody that's supposed to be tracking and keeping, who was it, when was it, what was the date, what kind of implant was it, that kind of thing. So we
Yeah.
keep those things
Smoker,
going. Yeah.
diabetic, the suspects, the usual
Yeah.
suspects.
Talk about patient selection. I wish I had published this study, in-office study. This is more than 15 years ago in my practice.
Yeah.
I was a, you know, brand new dentist. I was doing a lot of implants. I mean, not into my training now, but I was doing a lot of implants, but I was a heavy general dentist, right? Doing, I don't know how many implants a week, whatever.
Sure.
And I was like, I was thinking to myself, ego, I'm shit hot. Like I might
But we all get
99%.
that moment. Yeah.
Yeah. I'm like, oh, placing all these implants. What's your failure rate? 1%. It's like everybody else, 1%.
Yeah. Yeah.
And
Small.
then I got the idea, or I don't know, someone suggested I should go back and take a look. So I started like, okay, I got my staff. Long story short, tracked like 600, whatever, some implants. I think I remember the 630 number. First 630 implants, and I looked at my success. It was 94.
Yeah.
Okay.
Well,
So I went,
statistically,
holy shit. And then I was like, I thought I was better than this. So I went in and started looking at the failures. Now, I've learned two things. If you threw out my first, I don't remember, 20, 30, 50 implants, okay? So there's a learning curve to learning. If you threw out
yeah.
the implants that happened in the first, whatever that was, 30 or 50 implants, I got up to like 97, 98. Then if I threw out all the patients that I found out later were diabetic or heavy smokers, I was at 99.
Yeah.
And I realized I did one thing right away. I started sticking people for A1C or getting an A1C test.
I still don't do that, and I probably should. I do a lot of medical background. I talk to them about it, and for people that are super,
Yeah,
people will say they're healthy. This is a common thing. They say they're
yeah,
healthy, but they've never
yeah,
been to a family physician, right?
right. Yeah.
So, they could have hypertension, heart problems, hyperlipidemia, diabetes. Um, I don't stick everybody, and I probably should,
Dude, you can do it. I
honestly.
got my treatment coordinator knows how to do it. If and they'll do it for me. They'll be
Yeah,
like, patient's ready to go, single implant tomorrow, and they just haven't been to the doctor in 10 years, and they'll stick them, and they'll get
yeah.
me an A1C reading because I
Stick.
got bit. I got bit.
What's your number? What's your A1C number? This is important.
Yeah, so I mean, obviously we like it under a 7, 7.2 at the highest. I think I've got a little clinical range there up to 8 if I want. And then I start to be
Yeah.
like, no. What's the
Well, and I think the valuable thing too is like that's a 3-month turnover. So if you see them 6 months ago, and
Yeah,
like right now they've had Thanksgiving, they've had all their Christmas parties at work. You're
right.
about to place a bunch of implants, and I don't have this. I bet if I stick a lot of my patients, they're way up. I bet. I don't know. That's a that's a value point.
I just know because I personally was hurt with the 94% number. So I started looking at it. Hey, I had a full large consult today, and the guy was pulling out his wallet. Let's do it. I want to do it next week, and he hasn't been to the doctor. And might be proud of this from a GP, but I'm like, no, we're getting an HMP. Like, I'm not
Yep.
trusting your little dental health history that you filled out today. I get HMPs and an EKG. EKG on everyone over 50. It might be a little aggressive, but I want to know.
Not aggressive. The thing about it is, as providers, we have a very low mortality rate with sedation, right? We really do. And if you're outsourcing your sedations, it's probably even lower depending on who you're utilizing. But we have no one expects to die or have a morbidity in a dental clinic. And the optics of that can crush you.
Mhm.
Uh really. And truly, you think about why we do it is for patient comfort. It's elective in a lot of ways. Unless they have super phobia. I mean, raise your hand if you've done an all in four under local. I mean, I've done that. People can
Yeah.
do it. I've done a zygoma under local. I wouldn't recommend
Yeah.
it,
Yeah. Was that
but I've
fun?
done it. And good localization should never be, you should never hide a bad anesthetic with local. And you should never ever do a sedation without being really, you know, prepared. So I
Yeah.
think that's good on you, man. Good H&P.
Just want
It's
to,
that's real.
knock on wood. We don't want to be in the news, right? I mean,
No,
somebody just
dude.
passed away in Florida, and I think the news story was person dying to have a smile. Like it's ridiculously morbid. And you're right. But I mean, people will have mortality in a knee operation. I mean, it doesn't. Sedation is sedation.
Yep. That's the
Yeah.
most dangerous thing that happens in your office. Not, we talk about pterygoids and losing them and hitting bleeds and stuff. That's not even the dangerous thing. It's the sedation. That's the dangerous thing. You're not likely to kill somebody unless they were already you just pushed them over the edge and they're already gonna have a problem. You know what I mean?
Do you have a BMI threshold for an outpatient surgery center?
I am good. So, like I said, I'll give somebody with a really high BMI of like 1 upper said, 2 upper said. They won't
Yeah.
remember anything. For Just keep them upright and just numb the hell out of them. You know what I mean? And then
Yeah.
once they're numb, they don't care. You know what I mean? But like, so I fudged that a little bit,
Yeah.
but I would not go crazy with if you have somebody that you don't trust or you don't know well to do your sedations and they're not comfortable with it or they feel cocky about it. I
Yeah.
just listen. It's safer. Let them get on Ozempic. Come
Yeah.
on.
We're at a 40. At a 40, they have at a 50, no way. At a 40, they have to meet my anesthesiologist, and he has to do a physical exam before the day of.
Yeah.
But I say that, dude, if you can't see me, but I'm not that fat, right? But I'm like a
No.
38 BMI, but I'm like 5'11", 215. And
Yeah.
for the record, the physician said I've got 106 pounds of muscle in here.
There you go.
But
There you go.
I'm a 38. Like I almost disqualify myself from my own place,
Oh
you
yeah,
know?
man. Well, and the other thing that you got to worry about too is people that with sleep disordered breathing. I mean, sleep
Yeah.
apnea. I mean, or somebody that's got like a super protruded chin. Like you don't have to have a high BMI to have a terrible airway.
Yeah.
So, if you don't know how the Mallampati
Yep.
score, and sedations in your office, you should know it because they could have a great BMI, but just have a terrible airway, and
Right.
then that's a bigger indication for you being able to tube somebody than anything else. So, yeah,
Yeah.
I mean, complication management, just knowing the psyche of your patient first, knowing like having everything ready, doing those pre checks,
Yeah.
A1C. I should probably start doing that. I'm gonna actually ask you for that in office monitor. I'm probably gonna get one.
Oh, just go on
Now I'm
Amazon.
like,
You
now I'm
you
thinking to
could
myself, I don't want to have a 94% success rate.
Dude, you can buy a kit on Amazon with like 50 test kits in it. I mean, they're easy now.
Really?
Yeah, they're easy to
Okay.
find.
Cool, 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 cool.
Um, I think we're talking about it, but like you being dual degree certified, what's the one thing that you wish dentists understood more about medicine?
I don't know. That's a tough one. I definitely think that it's like your medical history is overlooked. So I went through medical school and I went through dental school. And medical school, so dental school, for example, was tough. And I think it was a little tougher than medical school because the the quantity of information we had to digest was way more. But in medical school, it was much more focused. It was much more in depth
Yeah.
on every system. And I feel like we got a light brushing of what everything means. Like we might know what it is, but how it's managed and what it means, I think, is not always covered very well in dental school. And diving into a good medical history for someone that's doing a lot of sedations, I think is super important. Um, Knowing your comorbidities of like what medical problems might have and what those medications are going to do for your implants. We're talking about implant specific, like steroids, um, antidepressants, um, you know, clindamycin, all those things, they're well published. Um, and knowing those things is important. I feel like you get out of dental school, sometimes you don't look at those things anymore. So
Yeah, I think it's true. It's funny. I got to sit for my boards again next year for Diplomate ABOI. It's been
Yeah.
14 years. I got to do it again next year.
Should I do that?
Diplomate ABOI? I mean,
Yeah.
dude, you've got everything right. Like
I
nobody
don't
would
know.
question what you're doing, but
That's true. Yeah.
I mean,
But you tell me what so for the because I honestly I'm not gonna lie, to me right now, those are characters. I don't even know what's that even entail. What's
yeah.
that go for?
So
Like,
again, I did this 14 years ago, and I was a board examiner for a little while with the AAID, not the ABOI. But I'll tell you, it's a it's a legit test. I mean, the test has stood through the merits of Supreme Courts in 3 states. Okay, it's statistically
yeah,
verified to be a good test. The way that they do the oral, the way they do the written, it's a fair exam. And if you ask anybody who's gone through it, it's pretty rigorous. And the reason why pharmacology drew my attention to that is because they beat you up in pharmacology. Like
I
you better
bet.
know everything about every drug. That and biomaterial. People always say, "What do I study for my diplomate board exams, my oral boards?" I say, pharmacology, biomaterials. You better understand what you're putting in the mouth on a high
Yeah,
level, on a molecular level, and you need to be well read in every journal under the sun for the last 12 months. Everything that's current literature.
yeah.
Now everything else, by the way, you need to know. You know, but
But also,
it was stressful, and I just realized I have to recert next year. It's only good for 15.
yeah.
Yeah.
Ah, you got it though. You're teaching the course. You'll help. You'll you'll get it.
Yeah, but I got to pull out pharmacology and do that again. It scares me to death. What
It's
scares
changed
you?
though. That by itself, I think in the last 15 years has changed tremendously for
For sure.
implant success. That's
For
the
sure.
one thing that I feel like it's just like, man, that just like people paying attention to how bone healing and how drugs help with that or don't help with that. It's
Right.
crazy.
You're right, because a lot of it was speculation 14 years ago.
Yeah.
A lot of it
Now
seems
it's
like it was.
statistically verified.
So if that scares me, Zach, what scares you when you get up in the morning?
Oh, I don't know. When I'm
What?
gonna get my next workout in. I, I don't know. Honestly, I will tell you the crazy thing about oral surgery is so when you talk about like the reasons why you do surgery, I mean, I do surgery because I love it, but you do not get paid to go into the hospital, period. Not at all.
Mhm.
And the liability on that stuff, we talk liability on all and X. That's there. That's real. It's tough surgery. It's high level. TMJ replacements, orthognathics. I mean, they're big surgeries. So it can be the liability on that sometimes just I still get a little nervous. I'm not gonna lie. When I have
Yeah.
a big, a 4-3 piece PSSO, I'm thinking about it the day before surgery. I'm like I'm planning through it in my brain to make sure that I don't miss a step, that I'm prepared and I'm ready for it. And that's applicable across the board. But um it's being ready for anything is a little hyper vigilant maybe.
I think isn't
That's what scares me.
Yeah, but isn't that also what makes you great? Is
Oh, what?
walking into everything with the reasonable expectation that, hey, if I don't do this right, it could fail, it could not go well, and being hyper vigilant so you make sure that it does go well. Don't you think that kind of plays into it?
Well, yeah, and it's a person, you know?
Yeah.
Everything we're doing is on people.
Right.
So, like your sister, your mom, somebody's family member, and, that holds weight, which is good. It gives so much value to what we do
Yeah.
because you're making people's lives better, but on the flip side, if you're doing stuff and you're not prepared and you're not trying and you're just trying to get in numbers and, look cool on Instagram, it's not where it's at. I mean, it's nice, I guess, to have some cool posts, but it's all about making sure your patient is taken well care of and,
Yeah.
you know, and that's the most important thing. And that's, I think, where you get a little bit of the scaries is like, you know, you don't want to mess up. You don't want to make someone's life worse. And we didn't get into this to make people's lives worse.
For sure. Yeah. Do
Yeah.
you ever? do you ever get the Sunday scaries, right?
Oh
Right
yeah.
before you go back to work, you're like,
Oh yeah. On it, like getting ready for I just caught up on everything. I have
yeah,
almost all my notes written, my emails are down. It's
uh,
like it's just about a new wave of business and
yeah,
patient care and it's you gotta take care of yourself, man. That's the thing. But I'll tell you, Sunday scaries are less now.
okay, how so?
The
Why?
because I'd say Sunday scaries are less because I I I don't take on patients that I don't want to take. I, you know, I maintain a pretty good like mental health regimen with working out,
Mhm.
with, family and spending time. And I just feel like all that stuff just makes your day to day like this is like water off a duck's back. This is okay.
Yeah,
We can manage this. So,
yeah. I'm just gotta put a shout out to you because, the drinking, like I'm off of it. Like I'm not,
yeah.
everybody I know that's doing well is off of it. And I think what a distraction that was and how difficult real life was
Yeah.
back then, to come off. I don't know about you, but like a lot of people like myself were proud of it. Like, oh, I can go out and I can still function at a high level, right?
Oh yeah. It was a work hard, play hard mentality.
Yeah.
Like, and then we're all so competitive. It's like I can play harder. I can, what
Who's the best
and
oral surgeon? Well, who's the best oral surgeon after
yeah.
a hard night?
Hmm. Oh
Yeah.
yeah, man. It was that high school, college mentality that kind of trickles into now it's your stress management. It's an unhealthy stress. Your sleep sucks,
Yeah.
your sleep quality sucks. Um, it helps a ton with
Yeah.
clarity and just staying in the moment and present and I don't know. I love it. I
Yeah.
basically if I'm like in Italy, I'll have a glass of wine for sure. I mean, it's
Sure.
Italy. I'm gonna try try a glass of wine maybe, but you know, day to day, why even mess with it? I have a lot of fun without it.
Yeah.
So,
I got to agree. I think we got to give a message for all the younger docs out there. Like, hey, man, slow down. Go
oh
soft,
yeah,
Yeah.
lowdown is like real. And I still have a problem with that. I was telling a patient today, I was talking to him, and a lot of my patients I have conversations with, and we're doing our follow up on an implant final check. And he was a little late, like it was like 6 months later. And he's like, "How you doing, man?" I'm like, I feel like I'm getting into a cycle where I'm overbooking myself a little. Like I'm getting a little too busy again. And I need to take a step back because the work will always be there. It's
Yeah.
not going away.
Hmm.
It's not gonna get any less work, but the rate of which that you're trying to push through life,
Yeah.
can just make you feel better or worse.
Yeah.
So, there's no balance. I don't believe in that balance thing where you, like, you're balancing a lot. I think it's all, like, entwined,
Yeah.
like, work and life is just kind of more like a mesh of just how you're living your day,
Mhm.
but you do need some semblance of balance, I guess, or
Yeah.
prioritizing the self. So
I'm fully, hey, look, I was in the hospital last week with, truly like technically septic from a kidney stone, kidney infection, bladder, prostate,
oh,
like
oh
blew it
man.
out, leukocytes, up near 20, all happened within about 4 hours. I go to the hospital to get an IV bag. I'm in there for 2 days. But I think, like my go, 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 never quit was affecting my health. I think that's why that happened. That was God telling me slow down,
Yeah,
slow down.
absolutely.
So, you know what I did? I didn't do this for the next couple of courses because they're scheduled, but starting in May, we just finished a 3-day remote anchorage, live patient cadavers, all that on a Sunday. I came back to work Monday. I was like, no, starting in May, those classes are Thursday through Saturday. I'm taking off Sunday.
Yeah.
And the other thing I
Lord's
did,
Day. Great
what?
excuse.
It's
Go to
Lord's Day.
church.
Yeah.
Yeah.
You
Get
can't
your
even
day
get the
off.
Lord's chicken on that day. I mean, like, take the day off. And then
Yeah.
I went after April 1st, I'm done working Wednesdays and Fridays. I'm just done, you know?
Nice.
And
Good for
I'm
you,
like,
man.
I work Monday, Tuesday, Thursday. Sometimes I'll come in for half day Friday, I decided. but I'm taking 2 days off. The work is, I need to spend time with my family, you know? I needed my help.
Yeah,
Yeah.
absolutely. Speaking of which, my kid's movie just ended, and I think I'm gonna do just that. Was this?
Okay.
Yeah,
It's a
we
good
good?
place. It's a good place for that, for sure, for sure. Yeah, you got to be a dad first.
Yeah.
I know that. Oh, there
Hi.
she is. Hey, how are you? Who's that?
This is Stacy McGill.
Stacy McGill.
Yeah,
Hi, hi, Stacy. Got
yeah.
is that the camera or is that cat kind of large?
It's a large cat. She's a rag doll. She's a pluck ball.
That's a
And this is
beautiful cat.
Madden.
Hey, Madden, how are
She's
you?
my co-chef slash marketing coordinator slash website model.
Yeah, right. Well, as long as a little bit of advice, and we can edit this out if you don't, you know, you might not want your
Oh,
daughter in there,
she's
but you let me know. But if you put your beautiful daughter and that cat in your marketing, you will get way more followers.
there
And
you
even
go.
if you don't want your daughter in there, that's fine. But that cat alone will get you more followers. Okay.
I'm telling you. She
Yeah,
loves this too. She's purring right now. It looks like she's not happy, but she's happy.
that's cool, man. You know, I put on my Instagram page implants, you put on their BSSOs and TMJs and all this bullshit. It makes you feel good. And you know, to some extent, there are people out there who love
That's
Dr. Pimple Popper
funny.
and they want to see that. But really they want to see my dog in the office. That's all they really want to see. Or my
Do you have an
baby.
office dog?
Yeah, Cooper. Yeah. He's home
I
now.
didn't know you went into your office.
Oh yeah, he sits right under my desk all day long, and the
That's awesome.
patients bring him stuff, and they all look for him all the time.
I'm
Yeah,
flying.
you're flying.
Yeah.
All right, man. This is
Hey, it
great.
was awesome talking to you, man.
It was great talking to you, man. Go ahead and I'll sign off, and I'll let you sign off, and I'll close this out. Merry Christmas,
Cool.
though.
Merry Christmas. Absolutely.
Yeah. All right. Good to see you, buddy. All right. What a great way to finish. Zach going to be a dad. She was good. He said, "Hey, honey, can you just watch this movie for an hour?" And Dad's got a little work to do. That was awesome. Well, that took me by surprise. What can I say? Great episode with Zach. Real talk, real conversation about uh, oral surgery and things that general dentists need to know, and things that oral surgeons need to know as well. He touched on that as well. So it was a real pleasure having Zach on there. I hope to talk to him again. Good friend doing beautiful work out there in Kansas City, Missouri, and a great all on four. I will say, if you're watching this and you're a dentist in Kansas City, Missouri, Zach is open for business and more referrals. He's spreading out that all on X practice. And he said, I only get the hard ones. I'd love to get the easy ones too. I can commiserate that. All my general dentists around here, that you guys send me the ones that all the specialists don't want to take. I also take the layups. All right. So that being said, let me give a quick shout out. The Atlantic Implant Institute. We're filling up Module 1 boot camp in January. That's January 23 to 26. Dr. Athena from 4M Clinic out in LA is going to be here, co-faculty, as is Dr. Brandon Coford with Smart on X Technologies. This is Module 1, which you can take by itself. It's also Module 1 of the Continuum 1, 2, and 3, which we just finished up a Continuum. If you have any doubts, you guys got to know this is a curriculum. This is a curriculum of education. This is not just a quick course in how to all on four. So look for that. Business of all on four is coming up in April, and I'm only going to do it once in 2026. So, you know, you got to be there to see that. And we just offered FP1 with Dr. Knife Sonata May 1st and 2nd. Probably the only time in 2026 is going to be here at the Institute. You don't want to miss that either. We got education for everybody from A to Z. Come check it out. Full education, didactic, hands-on, live patient, and cadavers. You get it all here at the Atlantic Implant Institute. Until next time, y'all have a Merry Christmas, Happy Holidays, Happy New Year. I'll see you guys soon. Take care. Have a great day. All right. That's a wrap.